Good afternoon, everyone. Hello and welcome to this talk by Shelley Hearne in the Dean Speaker Series. I'm John Samet, the Dean of the Colorado School of Public Health. I'm delighted to have the opportunity to introduce Shelley. We've been friends and colleagues for a long time through various adventures, misadventures in
misadventures
in public health. Don't interrupt the Dean.
I have just as many stories on him, so no worries, no worries.
So we're gathered here. So by way of introduction, when I thought about people to come and talk to us in the School of Public Health, Shelley was one of the first people who came to mind because we have a lot to learn from her. She knows us. She's taught in the academic world. She has a DRPH from Columbia. But she's ventured well beyond the bounds of academia throughout her now long career.
Yeah, don't say how long.
No, not saying how long, 30 years. And over that time has really been involved in a number of really important initiatives, such as CityHealth. She wandered by to say hello to Mayor Hancock yesterday around CityHealth issues, but previously with the Trust for America, looking at the environment and its impact with Pew and with others. And, if you start talking to her about projects, they just keep coming. And they all have to do with trying to make people and places healthier. And they draw on what it is we do within academia and beyond, but she has a keen ability to integrate and to communicate. So we just had a small workshop for faculty interested in that process, taking what happens on the academic side and moving it out into the world, translation. So she's going to talk with us today about her experiences, and there's the title, Policy is the Prescription for Catalyzing Change in Denver and Beyond. So Shelley, thanks so much for coming.
Thank you, John. Well, I'm a believer that we can't just preach from a mountain. You have to know where the people are. So I might do this lecture from here, because you're not coming down in front here with me. So I got to come up with you. Is that cool? Yeah. Or should we come in closer? Greg, lead the force. Though he has his jacket on, doesn't he? He has that look like he's ready for a fast departure. Yeah. Thank you all for being here. I do have a bunch of slides, but I also, I'm a practitioner, and I have spent a lot of years, it's what the white hair is about, looking at how to move and advance policies at the federal, state, and local level. I've not really had international experience except for a board, ironically, that John and I served on for many years together in Japan, dealing with the survivors of the atomic bombs. And that I've learned a lot from John. I also, just a spoiler alert, I have some compromising pictures of him at the end of this lecture. Because I think it's important to you all have a full picture on the kind of engager he is on public health matters. That's all I'm going to say right now. We'll leave it for the end, and he is looking nervous. But we've agreed what happens in here. I mean, you can tweet at CityHealth. We love it, and also at Shelley Hearne, and we'll tweet back, and we'll continue on this conversation. What I want to do is talk a little bit. Over my 30 years, I've worked on things like the passage of the Food Safety Modernization Act. I've worked on the passage of the Credit Card Reform Act. It had a more official title of Credit Card Accountability, Responsibility, and Affordability Act, and a lot of other federal bills, in addition to a few state ones when I worked at the state level for New Jersey's Department of Environmental Protection, because I think, one, you can be an extraordinary advocate and facilitator of really smart public health-driven decision-making by being on the inside in agencies. In fact, you could be a smarter advocate by having that government experience. Understanding how decisions are made, why they're made, makes you more effective if you're on the outside in terms of you can't just give data the way you think makes sense. You have to understand your audiences. You have to understand what communities need and reflect your information so that it's helpful to them, and vice versa. This is the whole world of community-based participatory research, is really listening and being able to understand how to engage and cross those worlds. And right now I'm spending my time at the local level and working and focused on the 40 largest cities in this country. It's actually been such a successful policy advocacy experience. Initially I strayed away from federal work because it's been a little paralyzed and difficult to find bipartisan evidence-based solutions at the federal level. And the city level has been extraordinary. There is a hunger, doesn't matter if it's Republican, Independent, or Democrat-led, mayoral level, city councils. They're still really focused on how do you keep cities healthy, thriving, economic engines, epicenters. I used epicenter wrong, sorry. This is an audience that will catch me on that. Epicenter only is on earthquakes. It's not an epicenter of disease. That they're hubs of innovation. And so you may have evidence for some new ideas on what policies could work that you can actually get a city, especially a place like Denver, where you've identified what are some of the thorniest problems, challenges, but you've got the data to show what, in fact, might be a logical solution. And there are ways to work across the aisle. And it's happening over and over. And I've, if I had gotten a little frustrated in recent years at the federal level, and I'm not saying this in a who won the last election. It was going to be that way regardless of who won. Really was. It's just what's been happening there. The city level, we're working as closely with Republican mayors as we are Democratic ones. And in fact, some of the biggest successes we've had on pushing some really what people had termed, I'm not sure what the technical appropriate phrase would be, but when we first came out promoting Tobacco 21, moving the age from 18 to 21, people were asking what we were sniffing, what country we had come from. It was absolutely considered impossible, and the data was actually quite thin. The only piece really supporting it at that time was the Institute of Medicine, still was called IOM then, now the Academy. And it was taking a look at some other patterns, but we saw that some of the most important successes were actually places like Denver, which was able to move forward on advancing the tobacco age to 21, and then the city of San Antonio, which is not a hotbed of radical public health policy ideas. It is a bread and butter, meat and potato, military-based city in the heart of Texas. And it has actually become one of the bellwethers of pushing and advancing public health policy. And I'll talk about why, and I think give you some insights on how we can really take your information, what you know, be incredibly effective policy engagers, influencers. I'm seeing over and over examples of a handful of people who are willing to think a little differently and do things a little differently, have extraordinary success at the local level, and it's bubbling up. So the T21 example, that never would have been imagined 3 years ago that you could have had something that passed nationally. Absolutely impossible. And it's because places like Denver and San Antonio took the step forward, and that was a key element in moving that agenda, that policy forward. So let me talk a little bit on this. Feel free to pepper me with questions or disagreements. We're advocates, right? You gotta continually kind of push and challenge and question, so that's great. I'm going to focus in on CityHealth, but I'm happy to talk more like some of those national policy work that I've done, the Credit Card Act, for example, which was back during the financial crisis, people were asking why was the Pew Health Group leading that effort on credit card reform. And we came across this as a health in all policies approach, that the financial security of a family, and in fact, those who were really being bankrupted most by the predatory practices at that time by financial institutions and credit card lenders, our research, our analysis had shown that all 400 cards that were on the market at that time had at least one practice, one policy in that credit card contract that the Federal Reserve would have qualified as predatory, as unfair and deceptive. We used the Federal Reserve's language. We did an assessment of every single card, so it wasn't a choice of, well, if you don't like this one, go to another one. It didn't matter who you were. And one of the primary drivers into bankruptcy or choices about, do we have a good house? Do we have a roof over our kids' head? Are we access to food, access to medicine? Those choices were being taken away because of the drive and push into bankruptcy. That's a public health issue. And it's why so many of you now are working on a really extraordinary range of issues. And it can go from financial security to violence prevention, gun control, transportation, housing. Did I hit a few topics that don't normally what we call health, but are you interested in any of those? Yeah? Got a few nodding heads. I think you all are, and that's why you're doing this work. And it's why we have also a challenge on people often don't understand what public health is. But I think we're much of the angels, the advocates, those who are really getting in some of the evidence into driving a healthier environment for all of us. So I don't have to, I'm an outsider. I mean, I'd love to live here. It is one great place you got. And it has a reputation out there of being one of the healthiest places in the country. When I was with Trust for America's Health, we would score routinely on the obesity. Who are the heaviest cities? Countries, cities. What am I working on right now? States. And Colorado was always in the top ranks. And there's this image out there. Everything's great. Everyone's young, exercising, lots of money. But you know that there's another story here. And good health is not necessarily available to everyone. And there are different tales and different stories. And there are Denver, Colorado rank high, but it also has a series of some significant health disparities that I'm sure many of you are focused on in this city. This is just grabbing from a few, which is coming out of either the health department or the county health rankings information sources and a few other places that you know. You see disparities. Again, Colorado may be the least obese, but you have great variability based on race. Infant mortality is a whole nother story. You have twice as many deaths for a black woman than you do for white women. Firearm safety is also another racially divided story. And that some of the challenges that we all face in terms of, we do know that gun control is a polarized political issue. And here I was just talking about, you can do things at the local level. It's really tough at the federal. Well, I'm not going to be the Pollyanna here and say, everything is completely different in our urban settings. We do still face some of challenges on how things are perceived and what are the policy solutions. But there are upstream efforts that can be done. Some of you does anyone work on gun control, violence prevention issues in here? Okay. Greg and We actually recently hired Daniel Webster to put a thought piece together. Daniel is a top gun control researcher in the country, and asked him to evaluate for us what would be if you could take the evidence, what's experienced globally, the best efforts to reduce violent crime. And this is asking a gun control expert. What would be the policies that you would recommend that we consider at the local level? And what he came back and said is the cities are actually preempted. Almost all cities are preempted from much of the gun control efforts. But two of the most impactful policies that you could do to significantly reduce violent crime, talking about armed robberies, murder, domestic violence, it is to regulate better alcohol. And there are two elements. You go take a look at CDC's, CDC-sponsored community guide, which evaluates policies for their impact and level of evidence. And it's taxation of alcohol. We haven't touched taxing alcohol in decades. Decades. And yet, what did we learn from cigarettes? You want to reduce youth exposure. You want to reduce overall exposure. Tax cigarettes. One of the biggest impacts in reducing tobacco smoking in this country. We don't do that with alcohol. Yet, what we find is close to 50% of murders in this country have an association with alcohol consumption. And that's true with most violent crime, more so than drugs. So it's taxation, and then it's also about regulating the sale of alcohol. Not saying you can't have it, not even saying about bars and restaurants. It's actually the density of carry-out to alcohol sales in a neighborhood. And you ask the cops anywhere in any city, and the locations, when you've got 4 liquor stores on your neighborhood corner, those are your hot spots of violent crime. And coming out of Baltimore, the Freddie Gray riots, one of the big demands that the community wanted was for the politicians to address this overabundance and concentration of alcohol retail sales in their neighborhoods. And it still hasn't happened. That's a community want, a desire, but this is a tough one, in part because of the industry behind it. And this is where you see places like Hopkins and the research they do on injury prevention really focused in on some of the alcohol work and what can be done. Again, it's not saying alcohol's not happening. Bars, restaurants, et cetera. It's the carry out in concentration. So my basic point is what you all know, but is actually a surprise to so many in the policymaking world, that there are a credible number of solutions available to us on some of the toughest public health problems that we face. From financial security to violence, as we were just talking about, to tobacco and on down the line. And there are actually policies out there that we can be using that can really drive addressing these problems in an equitable way. Because we do know there's more and more research on how policy has actually contributed to the health disparities in this country. But it's policies that can be the solution to get us out. And that's where, again, so much of your work, whether you're in epidemiology, the environmental health toxicologist, socio-behavioralist, whatever your disciplines are, there's so much that can contribute to how we talk about policies, and that as a public health force, that policies are our prescriptions to a healthier, more equitable environment that rises all boats. So, CityHealth, and I've certainly jumped to cityhealth.org for any of you who want to really dive in deep to some phenomenal data. it's an initiative of the de Beaumont Foundation and Kaiser Permanente, launched 3 years ago, with a simple concept of, and I can say this in this room, looking at the social determinants of health, housing, education, transportation, again, financial security. What's the best evidence out there that cities can actually have jurisdiction over, that will address equity and have a pragmatic way of making a difference in people's lives? And what we've done is curate a list to start of here are the 9 laws, here are the 9 policies that you should have on your books if you want to create those vital conditions for everyone to live a healthy, thriving life. And these are the 9. This was developed actually back in 2015, but first scoring using a policy surveillance, legal epidemiology methodology. I never get to say that, but I'm in a public health audience, so it's fun. But what the 9 areas are affordable housing. The policy right now in the books is inclusionary zoning, which requires in new development where there are at least 20 units that you have a certain portion are affordable for low, middle class income levels. Basically, you do assure your teachers, your firefighters, your cops have a place to live in the city that they teach and protect. Alcohol sales control, I mentioned before, and what we do is look at the regulation of alcohol outlet densities. Complete streets, some of you may work in transportation. It's basically the policy that requires all modes of transportation be accessible to all ages, all races, all types of modes, and do it safely. So cars are not, the roads in cities are not to create efficiency for cars. They're to create safety for those walking, biking, scootering, you name it. Earned sick leave requirements for all businesses and city employees. The food safety restaurant inspection is, every city has a health department, or a county does, that does the restaurant inspections, but few of them make that data publicly available in a way that actually matters to the customer before they go in the door. So this is the idea of ABC, or put a number, or in Seattle they have emojis. And you can imagine what an F looks like with an emoji. It's not pretty. But they did this because they have 300 different languages in their city, and they needed a different structure. But it's to translate the thing that public health departments do and people really care about. It's like advertising for the health department. To have that at the front door, people really want to know it. They have a right to know it, and here's a translation. The irony is sometimes it's our health departments that fight us most on that policy. Healthy food procurement is the requirement that any food sold on city property meets nutrition standards. There's a radical idea. High-quality universal pre-K. It's 2 components. You have to meet the benchmark standards that have been developed long ago on what's quality pre-K, and you also, in order to get a gold medal, have to have accessibility measures too. Pre-K is one of the biggest health impacts out there for long-term outcomes. You have a really good quality, high accessibility pre-K program. Some of you may be working in this area. It decreases teenage pregnancy rates. You see higher graduation rates. You see higher fiscal security for all kids growing up in that location. It's incredible where education makes a difference in health. Smoke-free indoor air. Come on, who doesn't have that? It's amazing when we first launched this, how many cities still allowed smoking in restaurants and bars. Remember, we just started scoring in 2017. And I have some crazy stories to tell you on that one. Tobacco 21 we touched on, moving from 18 to 21. What we do is, for the 40 largest cities, using a team of lawyers, we assess the 40 largest cities on how well they're doing on those 9 laws. We look at all the codes, regs, executive orders, any acts that have been passed, and score them on a quality benchmark on how good a law, if they have it, how good is it in place. And to do that, we give a gold, silver, bronze, or no medal in each of those policy areas. And then we give an overarching medal based on how well they've done. And any city who wants to get to gold or wants to work in one of those areas and wants help, we provide technical assistance. And we go out and find the subject matter experts that work, that are credible in their communities. So, for instance, we worked very closely with San Antonio to help with the passage of T21. It wasn't CityHealth dropping in. We went and provided a grant to MD Anderson and their tobacco specialists to be able to fly to San Antonio, and they were trusted. They're their local top-notch resource, and they worked hand in glove with the mayor's office and others to put together regs that created one of the best T21 laws in the country. So we chose these policies because all of you are thinking, well, why didn't they do X, or why didn't they do this one? And it was a fascinating process that took about 18 months to get to that 9. There are hundreds and hundreds of policies out there that could be considered, and we actually did. And what we did was took every evidence-based policy that is known out there to have an impact on those social determinants of health. And so we took the CDC high 5 list. Is that the high impact in 5 years list? We took the community guide list. We took Robert Wood Johnson Foundation's action guide, which has probably 200 policies right there. We looked at the the Academy of Medicine's various reports. That's where T21 came from. We took all that already very credible third-party validators said this is evidence-based, and then we put it through a series of filters. What of those policies are under city jurisdiction? I'm not going to ask them to do something they don't have authority on. We then put it under a pragmatism test. And that was, it had to have evidence that it had worked in at least one U.S. city. Couldn't be France, couldn't be Denmark, because we are parochial. And we don't like what goes on. Even if it makes good sense and good evidence, we want to see it worked in a U.S. city. That was one test. We looked for bipartisan support, evidence of it somewhere. Doesn't have to be everywhere, but somewhere that you'd seen that kind of passage. We then gathered together a policy advisory group that had, we actually thought an influencer of city policy. We had a dean of a school of public health. We think deans, go figure, John. We think deans are influential with policymakers. We had a Chamber of Commerce involved. We had a Republican mayor. We had the CEO of Consumers Report. We had a number of health organizations representing vulnerable populations. It was a Noah's Ark. And we had them say, could you support this? Could we get key influencers to be behind it? And that's how we got to the 9. And we worked then with the key subject matter experts in each of those areas to hammer out what would be gold, silver, bronze, and no medal. And I must have hit the wrong button. There we go. So and then I talked about we give the overarching medal, and to get gold, you don't have to have all 9. You got to have 5 out of 9 are gold in one of those policy areas. And you can see down the list, 5 have to be silver in order to get silver, and then bronze is a 4 with any kind of medal. So we just released, as part of the U.S. Conference of Mayors, the scores for 2019. And this is how it stacks up for, am I in your way to see things? Are you okay? All right. Gold, silver, and bronze. And it's been an amazing trajectory. Again, this is just the third year that we've done measurements. And those of you who have been involved in the sausage making of policy know that nothing happens overnight. Sometimes you don't even want to know what's going into the sausage. It's not always pretty. And we've made a commitment that we don't change the policies. We reevaluate and update and modernize every 5 years because it takes a long time. It takes a minimum 1 to 3 years to get a policy moved. That's general experience. It's not what we've seen in CityHealth. Sorry, guys. You probably care a little bit about how Denver's doing. And here's what we scored. You can see the goals are in safer alcohol, indoor air, and tobacco 21, and then the rest of the makeup. They moved from last year, they were a bronze. They moved up to silver because, as mentioned, Denver worked really hard to get this tobacco 21 law passed. It was not an easy measure, and it took some really clever advocacy work, really building some constituencies and a lot of labor. I did meet with Mayor Hancock yesterday, and it was specifically to talk about, if I were going to boil it down, it was, dude, didn't say that, but kinda. He said, anyone work with the mayor, know the mayor? He's a little competitive, and he's close with the mayor from Atlanta. So I of course mentioned Atlanta's in the same exact place. They just moved to silver, and they're inches away from gold. And wouldn't it be great if Denver got gold before Atlanta? And shouldn't we have a little bet with the mayor, maybe? And his eyes light up. The mayors want their medals. It's fascinating. They really want their medals, and they want to be able to say, it's not a ranking of what your health outcomes are. It's a ranking of what you have control of actually doing and making a difference. Because on a lot of those health outcomes, when you see the county health rankings, the quickest way to move up in the rankings is gentrify. And that's not the public health solution. What our solution is, go and find the policies that create the opportunity that everybody can have those extraordinary health outcomes, because it's doable. And there are solutions out there that are in a policy landscape. And when you get mayors and council members excited to get their medals by putting policies in place, you got an opportunity. And that's what we're seeing happen. Just from 2018 to 19, we had 10 cities moved up in their rankings. Very deliberately, and amazing is a lot of them were in the, okay, thank you for my to-do list of the 9 policies. I'm going to go through and check these off, and I'm going to put them in place. That's not how it normally happens. But this is getting back to cities are about, they're pragmatic problem solvers. They want to be the best. They want to have the place where it draws business in, that people want to live there, that these are meccas for thriving environments. And we have watched city council members and mayors go through, and San Antonio is an example of it. They were no medal when we first did this in 2017. And the mayor said, I want my gold in 3 years. They were a no medal. I mean, nada. And they went and passed Tobacco 21, earned sick leave. They have a premier model universal pre-K program. They did healthy food procurement, and they did complete streets. And they want to do more. They already have their gold. They're asking if we could do a platinum. I'm like, sure, Mayor, whatever you want. But what he really wanted was that medal, and we had an extraordinary event at the U.S. Conference of Mayors in front of 1,000 of their peers, where Ron Nirenberg came up and had his gold, and he didn't know hoot about public health before, but he's become a crusader. And as someone who's gone through 30 years of advocacy, I came out of the world of Rankum Spankum. Trust for America's Health puts out the who's the heaviest states, or who are best prepared for a major public health emergency. This is something I would call rank and thank, and it's actually working better. And it's a little bit of a reflection. Times have changed and we're doing things differently, but it's also we are in this together. Policymakers want to create healthier environments. They actually care about health equity. That was what the shock I had in the polling work that we did. I thought that was code in public health, but it actually is something they are paying attention to. And so we're expanding. We're going from 40 cities to 75. We're in the process of updating our policies. There are new best practices in cities. We are hearing from people, actually from mayors and health commissioners, we should have a climate and health medal. So we're going through that process right now to add on health. We've been looking at mental health, something we were supposed to have 10 policies originally. We ended up with 9 because we could not find an upstream, city-based prevention policy to address mental health. We can talk a little bit about that more if that's of interest. We've had such interest from beyond the biggest cities. We're having small, mid-sized cities come knocking on our door and want to get scored. They want to get acknowledged for what they have done and where they need to do better and want to have it be visible to their communities. So Robert Wood Johnson Foundation has just given us a grant to create an opt-in program, and we just advertised it 2 weeks ago, and we got 800 applications. Oh my God. We're not that big. This has been an experiment that has more than taken off. But what I'll tell you is that we have an incredible data source. It's all online. With this policy surveillance, what we've done is create, building off this new field of legal epidemiology, we have every one of the laws that we've talked about and looked at is coded and on an Excel spreadsheet for the different components that should be in there to hit those benchmarks on quality. The data sets are all open. They're all available. We've been seeing a bunch of, everything from people doing dissertations, pulling out this data and connecting it to health outcomes, doing comparisons to other cities at a much more granular, thoughtful level. We're an accountability operation, and we're translating it for policymakers. But there are so many other ways that this database could be used, and we welcome a free-for-all. Go have fun with this. There's some really powerful insights to be had in here. We just, again, it's a handful of people. But what we're finding is leaders matter. Leaders matter, and the cities that have really gone to gold and where we've seen the change is because someone's wanted to own it or someone from the outside's been driving it. And that's probably a lesson that I've seen over and over in advocacy, that it takes a community, it takes a village, but you really have to have people out there to help get it over the finish line, to have the energy, to have the charge. Because in our fields, being those translators and being an advocate's not always been the easiest thing. We're not always rewarded for it. We're not always encouraged. I think, in the more recent years in public health schools, you're seeing more and more people stepping up with their data and being part of helping answer these really tough questions we got there on health and being part of the fix. I have poster childs in my life of who I've seen who've made a difference and how they've done it. And being a leader, you sometimes have to put yourself out there and you got to take risks and you got to do it a little bit differently. And I just want to give a shout out. I promised you pictures and I meant it. But John Samet is willing to do it differently sometimes. You have to take a risk when you're a leader, and sometimes that means doing things that you might think are a little foolish and stupid, and you worry how it'll be viewed in the future, and he's right on that. When I made John stand behind the stewardess outfit in Tokyo airport, I'm not sure you were anticipating the dean's lecture to end this way, but
I knew it would show up somewhere.
You knew it would show up somewhere, yeah. That's why the face is the way it is. But I am serious. I actually, I've always been a practitioner, applying what I learned from public health school, and I did teach health advocacy at Hopkins. And Greg suffered through that class, but what I used to have John come to the class and give a lecture because 20 years ago, the word advocacy was a dirty word at Hopkins. If you were an advocate, then you were putting your science at risk. That is not what you were supposed to do. That's not what a real researcher would do. And John was, as the chair of the EPI program at that time, understood that the science that he had on particulate matter, PM10, or his tobacco work, he was one of the top respiratory epidemiologists. I don't have to say anything nice about him, just FYI. I don't generally gainsay nice things about him. But I am grateful because he would come in and be willing to talk about it was a responsibility, it was an ethic of making sure that the data that he had, just as EPA was deciding about setting the rules on PM10, this is the guy who the science it was based on. And he was willing to go down and translate, those esoteric, nice papers that you get credit for in the academic world, but translate it for the actual people who were having to decide how to write the rules and regs and do it in a way that they would understand and be able to use. And that's called public health. We're not the medical school. We're not a health institute. We are a public health field. And that's exactly the kinds of things that we not only we should do, but the communities that we care about desperately need us to do. So that's my policy makes a difference in public health. You all, in all the work and the different ways you do it, absolutely are part of that package. And sometimes you got to put yourself out there and take a little risk. Doesn't mean don't ever, if I tell you to stand behind a cutout cartoon, don't do it. But keep the faith and keep doing what you're doing. So.
If there's a lesson here, be careful what you pose for.
Yeah.
Don't be a poser. But we've got time. Shelley's not heading off to the airport for a little bit, so I think thoughts, questions, comments, and conversation. Chris.
So where do you see the most resistance? What kind of policies at the city level tend to cause the most resistance?
Well, I actually have a slide I didn't include that will help answer this. What this shows you is the uptake of these policies. So things like, this is a little old, because Tobacco 21's changed, but we're seeing a lot of uptick, a lot of interest in things like complete streets and pre-K, as cities are leading on pre-K. Where we're having the most difficulty is in three areas. Food safety, translating the health departments. Every restaurant gets inspected. Every one of them has a score. I dare you, go into the restaurant and try to find that score. It's not at the front door. And chances are, if you did find it, you probably wouldn't understand. I mean, you might if you're in environmental health sanitation field, you'll know what it means. But it's not intended for you who's paying for it as a taxpayer. We're getting a lot of resistance on that one because the restaurant industry doesn't like it. But there are a lot of places it's standard operating practice, including South Carolina. And I didn't mean to be, that's not meant to be disparaging. I love Charleston restaurants are great, and I feel good about going into them because of the information. But the resistance is coming from not just the restaurant association, but equally from the health departments, and that's a fascinating one. Alcohol sales, we touched on that already, and that's a tough one because of the industry. And there is absolutely no advocacy groups out there working on alcohol. Tobacco, still good and strong. Alcohol, MAD barely exists, and it's mostly on the breathalyzer is their focus, and that's it. And then affordable housing, which I noted was inclusionary zoning, we're updating that one. And there's been such workarounds inclusionary zoning that we're going to update that policy to deal more comprehensively with the challenges on protecting renters, looking at eviction support. We're looking at issues on rental inspection, and so safety, quality of housing, and then we're looking at affordability. So that will get unveiled in a few months. Those are the three toughest areas. Yeah.
That's really fascinating. I'm wondering if there's another level that you look at regarding the implementation.
Oh.
So you could have something on the books.
All right, I don't want you guys thinking these are the two toughest questions.
We talked.
Did you talk? All right, great. So this is the biggest weakness, Achilles heel right now of CityHealth. Again, we're new. And what we can do is measure what's on the books. That's what policy surveillance does. We have not figured out a way to measure across all these cities in a way that's comparable implementation. And it is absolutely a critical issue. The devil's in the detail, always. You can pass the greatest law, but if it's not implemented, not funded, and enforced, then it means squat. Squat translate here? Yeah.
So I have a tough question for you.
Oh, okay. I forgot about inline. Hello, inline. Thank you. 12, all right.
I'm wondering if you thought about...
All right, hold on. They need to hear you.
Is everybody here? Oh, okay, got it. Okay. Sorry. Okay. I'm wondering if you thought about this work at all from a rural lens. There you go. Or how you go about doing similar work for that demographic.
Okay, so I hopefully you heard the question being about how does this apply to rural? Well, it is called CityHealth. And it's part because a lot of these policies are applicable. And that's part what this opt-in program is about. That we've had cities the size, and I don't think it's called a city anymore, with 200 who have wanted to opt in. We contracted with Change Lab Solutions, which is an organization based in Oakland, California, does a lot of independent policy analysis and thinking for public health government entities. And we had them do an analysis on were these policies applicable to small, mid-sized cities. And for the most part, yes. Things like inclusionary zoning, some of them are obviously not quite right, but for the most part can. We aren't meant to be all and end all, but what we have seen is that a lot of the policies which are applicable across the board, we're seeing this city energy and passage is what's catalyzing national policy. My work in the past as an advocate had always focused at the federal level because it's more effective. If you can get a national law, it covers everybody, like the Food Safety Modernization Act or the credit card reform. But as I noted before, it's a little more challenging right now. It's not necessarily where you're best. It depends. I'm not writing off, and there are a lot of good work can still take place at the national level. But for the types of policies that we were looking at and the comprehensiveness, it's cities that are spurring the national change. T21 happened at the national level because of the domino effect and leadership in cities. And there are others that are coming along the pike in that way. Yes?
With the population explosion of older adults, by 2030, we're going to, for the first time in our history, have more older adults than we do those under the age of 18. How is that addressed with such a large population turning 65 only in the next 10 years? I mean, it's happening quickly.
Oh, I know.
We have services for you.
Thank you. Thank you. Thank you.
How is that being worked into this? Because when I look at those policies, I mean, you could kind of stretch a few, of course, affordable housing, obviously, is
Right.
one. But there's not a lot that's addressing the older adults.
Well, yes and no. On our policy advisory committee, wonderful fellow, he's not a public health person, but Rodney Harrell, who runs the AARP. Some of you don't know what AARP is, but it's for the old people, all right? It's for us. I've been a member for years. I think it's at 50. They send you the cards. The Association for the Advancement of Retired People, AARP, which is a wonderful advocacy group. Complete Streets is actually about making sure that transportation is accessible for all ages, and it really is designed so, like the lights, pedestrian light, has to be timed that an elderly person can cross the street without getting knocked off by a car or a scooter. Scooters, obviously got a little. So Complete Streets, food procurement is across the board. I mean, particularly as you look at recreation centers, elder centers, the foods that they provide have got to meet nutrition standards. Earned sick leave is often, the way it's built in, it's not earned sick for you being sick, can be, but it's also to care for parents. It covers the full scope of family definition. So, I can make the case here. Is it, we will have in the new the new housing component, there are going to be provisions in there in terms of what is a vulnerable population. But, we try to get the right balance. Yeah. Yes. Oh, and then we'll share with the online. No, you.
Well, this may be related to the response about some of the challenges in measuring across cities and impacts and how policies are implemented. But I'm curious about whether you've been able to at least assess in some way or develop a formula, if you will, in terms of impacts on equity and as it relates, even if it's city by city, which is awesome.
I'm hoping one of you is going to do that research. But what I will say is how we got to these 9 had a equity lens in it to get us there. So not only was it framed in the determinants of health, but Change Lab Solution has a great tool, an equity analysis tool that you can use to look at policies, whether you're developing new policies or ones that are on the book. I'm sounding like a Change Lab Solutions ad, but go to their website. It is a tool that's available for use. They're a really great resource. That is something that you can use to scan, and it's something that we've done. But you'll also notice on our website, and we're a translator to policymakers, you don't see the language social determinants of health. You don't even see equities, disparities a lot. This is about thrivability for all, and it's part how we put this out there and sell it to policymakers. But it was entirely framed and driven from a equity lens. But
we've seen that borne out, I guess, because I know that was based in science.
Yes, we know. So no. We're 3 years, and we're not doing yet the analysis to take a look at, okay, we've seen 50 mental changes in this 3-year period in if you use the analysis methodology in tobacco, I can estimate how many kids we've kept from smoking. We can do some estimates, but we actually haven't done any of that yet. We've been too focused on getting this happening, and what keeps me up at night with this when we first came out was we have 360 data cells that are also driven from a lot more than that, because we have to code each law, and we have 2 lawyers code each one to have we have a Cadillac system, but when you have then discrepancies, there's a huge machine behind this, and the error rate is extraordinarily low, but it took a lot of work to get there, and this is going to be a challenge as we get bigger and bigger, how we keep that kind of quality. But my hope is, and this is talking about the model, this is really good data that people should use. And when you go to the website, you'll see down way at the bottom it says dive deeper. Dive deeper is your clue of here's where you can click in to get the Excel spreadsheets, the coding methodology, all the language. And anyone who wants to do further analysis, we're happy to connect you to the legal teams that are doing part of this stuff. We want this to be used and help drive in a lot of these issues and questions. I don't know if you...
Maybe the last question from Jonathan.
I'm curious, so now there's 9 metals, and you said
Yeah, we'll probably end up maybe like 12.
And what are the additional
Well,
metals that you're looking
I
at?
can't tell you that yet. Actually, next week our Executive Governance Committee is meeting, which is representatives from Kaiser and from the de Beaumont Foundation. We just had the Policy Advisory Committee meet down in Fort Worth, Texas. The Honorable Betsy Price, a good Republican mayor, joined with, again, really fascinating group of people. AARP, Consumer Reports, the Kansas City Chamber of Commerce, which oddly is one of the biggest drivers of public health policies. They've gotten it that a thriving business environment is a healthy community. Really interesting work coming out of there. But we are going to look at, there will be a medal on climate. It'll probably be a multi-policy series looking at potentially things like electrification of the transportation fleet, commuter benefits, procurement practices on toxic products, greening. There's a number of ways it could go, and I think it will be a comprehensive one. Mental health's probably going to get folded into some of the greening types of issues with climate, so it's going to be a climate well-being medal. Again, it's a little difficult to predict, but there will be some more coming down the ways. And all of these are being looked at, have best practices advanced since we put this together. And actually equity is being built into Complete Streets and a few other places. As we've learned, like your question on implementation, what we're seeing with Complete Streets, it's really happening where the big developments are taking place, but it's not equitably being distributed in cities. And so we're going to build in a requirement. You can't get gold if you're just having really safe streets where you've gentrified.
Great. Well, thanks so much, Shelley. Now, Shelley will be here for a few more minutes before we ship her off to the airport if anybody has last questions or comments. So again, thanks so much.
Great. Thank you, everyone. Thanks.